Good morning and good afternoon. First of all, I'd like to thank you all for your attendance and sharing us your knowledge in the present webinar. And on behalf of Egyptian Fetal Medicine Foundation and me, I'd like to thank Dr. Heba Mahdy, a consultant obstetric and gynecology, for her presence between us instead of today is a working day and she should be in her hospital. Thank you, Dr. Heba, and I appreciate that. Actually, it's our honor to listen to you and gain a lot from your knowledge and experience. After that, I'd like also to thank SonoScape company and its distributor, ESMAR company, for their efforts and arrangement for this webinar. Also, I'd like to thank the organizing company, Pure Spot, for its effort and well organization. And at the end, I'd like to express my gratitude to Egyptian Fetal Medicine Foundation staff, especially my colleague, Professor Saad El-Gelany, Professor of Obstetric and Gynecology in Minya University, and Dr. Ahmad Khatib, Senior Specialist in Fetal Medicine Unit at Ain Shams University. And also I'd like to thank Dr. Irina Isa, Director of Egyptian Fetal Medicine Foundation, for her effort and organization and sharing in organization of this webinar. Today we will start now our webinar with my colleague, and I would like to introduce the moderator of the webinar, Dr. Saad, Professor of Obstetric and Gynecology in Minya University. Dr. Saad, okay, let's start.
Bismillah. Bismillahirrahmanirrahim. Thanks, Professor Mohamed Kamal. I appreciate your introduction. It's great to be speaking with all of you today. Hello, everyone, and welcome to today's session. Thanks for all attendees for joining us and spending some time for today's webinar. We'd love to hear from you as well as the feedback. And for those of you just joining us, welcome again. My name is Saad El-Gelany, Professor of Fetal-Maternal and Reproductive Health, Consultant OBGYN, Mania Faculty of Medicine and the Global Library of Women's Medicine Ambassador. Today, we presenting a very interesting and hot topics by eminent speakers. We will start with Professor Mohamed Kamal, and then we'll go to a live demo by Dr. Ahmad Khatib, and then SonoScape promo, and we'll end with a hot topic by Dr. Heba Mahdy. The next speaker to my introduction is my great friend, Professor Mohamed Kamal, who is currently Associate Professor of OBGYN Fayoum University, and he is the President of the Egyptian Fetal Medicine Foundation and ISUOG Ambassador in the Middle East and North Africa. All right, let's turn to Professor Mohamed Kamal, who will talk to us about the role of ultrasound in twin pregnancy. Professor Mohamed Kamal, please go ahead.
Thank you, Dr. Saad, for your introduction. Today, my topic will be about the role of ultrasound in twin pregnancy, and it is ISUOG practice guideline. It is one of the ISUOG practice guideline. This guideline released in 2016. And first, before we go through the lecture, I'd like to give you some question in the form of poll. I will give you one by one, and please share us by your answers. And after that, at the end of the lecture, I will give you the test again to compare the result between pre and post test. And after that, I will give you the best answer. I will start now by the first question. Just you write your answer A, B, C, or D. اوكي، ما انا مش ما ظهرليش حاجه. اوكي، ما انا مش شايف.
نعم.
اوه سوري. اوكي، اه في الشات. اوكي. اللي بعده. اوكي. صح. خلاص كده. طيب لما تطلعني لايف قول لي بقى. Okay. Okay, thank you for your answer. I will start by my topic, and as we all know, the incidence of multiple pregnancy is rising nowadays, mainly due to delayed childbirth and advanced maternal age at conception, and also as a result of widespread of use of ART. Twin pregnancy is associated with high risk of perinatal mortality and morbidity in 29, and the associated stillbirth rates was 12 per 1,000 twin birth and 31 per 1,000 triplet and higher order of multiple pregnancies, compared with 5 per 1,000 single births. Preterm birth occurs in up to 60% of multiple pregnancies, and it leads to increased risk of neonatal mortality. 65% of neonatal death among multiple births are preterm, and compared with 43% of neonatal death in single twins, also associated with long-term morbidity. The outline of my lecture, and as regards the ISUOG guideline about the role of ultrasound in multiple pregnancy, the importance of ultrasound is dating of pregnancy, determining the chronicity and amnesty, twin labeling and the timing, frequency, content of ultrasound assessment, screening for aneuploidy, prenatal diagnosis of aneuploidy, screening for structure abnormalities and the diagnosis, management of discordant twin, fetal reduction, which is called selective termination, screening for preterm birth, screening and the diagnosis and the management of fetal growth restriction. And at the end, I will discuss with management of multiple pregnancy complication by single IUD. At first, dating of twin pregnancy is important to determine the actual date of pregnancy, especially in first trimester. We depend on the crown rump length, which should be between 45 and 84 millimeter, which is corresponding to gestational age 11 to 13 weeks plus 60 days of gestation. In pregnancies conceived spontaneously, the larger of the two CRL should be used to estimate gestation age. It means that if it is spontaneous multiple pregnancy and we have different in CRL, we usually depend on the larger one. Twin pregnancies conceived in IVF should be dated using the oocyte retrieval date or the embryo transfer. As regards determining the chronicity and amnioticity in twin pregnancy, it should be determined before 13 weeks plus 60 days of gestational age. And we use membrane thickness at the site of insertion of amniotic membrane into placenta, which is called T sign or lambda sign. And also we can depend on the number of placental masses. As regards amnioticity, should be also determined and documented because and the monochorionic monoamniotic twin pregnancy should be referred to tertiary center and expertise in their management. Here is the example of lambda sign, which is present in dichorionic and diamniotic twin pregnancy. We find a thick layer of fused chorionic membranes with two thin amniotic layers, one on each side, which is called lambda sign. On the right image, which is T sign, it presents in monochorionic diamniotic twin pregnancy. We have two thin amniotic layers separating the two fetuses. This is the T sign. Another example of the lambda sign is above one and the below one is T sign. What about chronicity after 14 weeks of gestation, which usually is hard to differentiate? We usually depend on the same ultrasound signs, which is T sign and lambda sign. Sometimes we depend on the discordant fetal sex to be sure that it is dichorionic. Transabdominal or transvaginal ultrasound also methods, we can use it after 14 weeks to be sure is it dichorionic or monochorionic. Sometimes we can't determine, and in that time we refer for tertiary center for expertise to assess the chronicity. And if the center is uncertain about this chronicity, in this way or in this situation, we consider the pregnancy as monochorionic twin pregnancy. Also, number of placenta is questionable because dichorionic placenta are commonly adjacent to each other, appearing as a single mass. So single placenta doesn't mean it is monochorionic. Sometimes it is dichorionic. And 3% of monochorionic twin have two placental masses on ultrasound. In monochorionic monoamniotic twin pregnancy, it should be referred to tertiary center with expertise in their management and follow-up. As labeling of twin fetus, which is very important, we should follow a reliable and consistency strategy and should be documented clearly in the woman's notes to facilitate the follow-up and the labeling according to the site, like fetus A in the right or left side or in up or down, up or lower. It's very important to determine the site. And as regards the mapping in first trimester, we can also determine through the insertion of the cord to the placental age. It is advisable to describe each twin using as many features as possible as to enable others to identify during the follow-up. I give you example like we can say twin A. Twin A is a female on the maternal right side with a posterior placenta and a marginal cord insertion. In case of discordant twin, also the labeling should be accompanied by description like twin A is a potential recipient or twin A is a potential donor. In case of monochorionic monoamniotic twin pregnancy, labeling is less accurate. And we should know what's called switch phenomena, which means twin A and twin B during pregnancy not necessarily be delivered in the same order, especially during cesarean section. As regard routine monitoring, I will start by dichorionic twin pregnancy. We should do ultrasound in the period between 11 weeks to 14 weeks. And this time for dating, labeling, determine the chronicity, and screening for trisomy 21. After that, we follow the patient at week 20 or 22. And in that period, we examine for detailed anomaly scan, assessment the fetal biometry, assessment amniotic fluid volume, and cervical length. After that, follow up in the case of dichorionic twin pregnancy will be every 4 weeks. And during follow-up, we assess the fetal growth, amniotic fluid volume, and fetal Doppler. But in monochorionic twin, as you know, we have a lot of complications that we are all afraid of them, like twin-to-twin transfusion syndrome and the TAPS. So we have another examination and routine, and with different period. In the period between 11 and 14 weeks, dating, labeling, determining the chronicity, screening for trisomy 21. And in that case, which is monochorionic twin, we start from 16 weeks, not 20 like in dichorionic, 16 weeks. And the period between 16 and another examination, which will be 18, we assess fetal growth, we assess the amniotic fluid through the deepest vertical pool and uterine artery pulsatility index. Here, as we noticed, the follow-up will be every 2 weeks. At age 20 weeks, we assess fetal biometry, detailed anomaly scan for both fetuses, and the amniotic fluid volume through deepest vertical pool, and Doppler through uterine artery pulsatility index and middle cerebral artery peak systolic velocity, and also assess the cervical length. After that, we follow the patient every 2 weeks through fetal growth assessment, deep vertical pool assessment, and the Doppler through examination and measurement of uterine artery pulsatility index and the middle cerebral artery peak systolic velocity. Screening for chromosomal abnormalities in twin fetuses. First trimester screening for trisomy 21 is important. We depend on combined tests, which include nuchal translucency and free beta HCG level plus pregnancy-associated plasma protein A level. And also we can assess through maternal age and NT. In case of we have vanished twin and there is measurable fetal pool, in this case we depend on maternal age and NT. The detection rate, as you know, may be lower in twin than in singleton pregnancy. In case of monochorionic twin, the risk of trisomy 21 is calculated per pregnancy because they have the same karyotype. But in case of dichorionic twins, the risk of trisomy 21 we calculate or depend on calculation per fetus. As regard invasive testing on basis of combined screening result, we get the combined result and we need to make an invasive test for confirmation. Invasive testing is greater in twin and carries greater risks like pregnancy loss, and which will be or estimated to be 3.8% in case of CVS and 3.1% in case of amniocentesis. There's no difference in risk between transabdominal or transcervical maneuver. There is no difference in risk using single needle or change the needle and use double needle system. And also there's no difference between single and double uterine entry. As regards cell-free DNA analysis for maternal blood for risk assessment of fetal trisomy 21, higher detection rate with lower false positive rate than does in combined test. In singleton pregnancy, the DR for trisomy 21 was 99%, and the false positive rate for 0.1%. In twin pregnancy, DR for trisomy 21 was 94%. As regards CVS, it is preferred in dichorionic twin pregnancy for earlier diagnosis for any aneuploidy. And as regard amniocentesis, if we have monochorionicity, here the fetus appear concordant for growth and anatomy, and sample only from one sac is enough. Implication of discordant. If we have discordant in NT or CRL between the two fetuses in first trimester. The management of twin pregnancy with CRL discordance, which is 10% or more, or NT discordance 20% or more, should be discussed with a fetal medicine expert. Discordance in NT of 20% or more is found in around 25% of monochorionic twin, and the risk of early IUD or development of severe twin-to-twin transfusion syndrome in this group is more than 30%. As regards discordance of CRL or in CRL of 10% or more, the risk of fetal abnormality here is high and estimated to be 25%. As screening for structural abnormalities, the risk of fetal anomalies is greater in twin, in around 1 in 25 dichorionic pregnancies, and 1 in 15 monochorionic diamniotic pregnancy, and to be 1 in 6 monochorionic monoamniotic twin pregnancies. Twin fetuses should be assessed for the presence of any major anomalies in first trimester and routine second trimester at age 20-week gestational age. Cardiac screening assessment should be performed in monochorionic twins. Here it is important in case of monochorionic twins for asking for fetal echo. If we have discordant fetal anomalies, 1 to 2% of twin pregnancy will have anomaly affecting one fetuses. In this case, the management is expectant management, or selective termination of the affected twin. Twin pregnancies discordant for fetal anomaly should be referred to a regional fetal medicine center, and the cases with high risk of intrauterine demise in case of dichorionic twin is recommended for conservative management, and in case of monochorionic twin, it is recommended for intervention. As regards selective feticide in twin pregnancy, in case of dichorionic twin, we can use ultrasound-guided intracardiac or intrafunicular injection of potassium chloride or 1% lignocaine in the first trimester. In case of monochorionic twin, selective feticide through cord occlusion or infrafetal laser ablation or radiofrequency ablation. As regards selective feticide in twin pregnancy, also in the second trimester is associated with high risk of miscarriage and preterm birth compared to with that in the first trimester, 7% risk of loss of entire pregnancy and 14% risk of deliver before 32. So it's important for early detection in first trimester and selective termination in first trimester. As regards screening for risk of preterm birth in twin pregnancy, cervical length should be assessed and preferred early for preterm birth for protection or screening for preterm birth, and the cutoff will be or should be 25 millimeter in second trimester. It is the most common used cutoff in the second trimester for twin pregnancy, which is 25 millimeter length. As regards what's called selective fetal growth restriction, here, it means one fetus, the estimated fetal weight is less than 10%, and the inter-twin discordance is more than 25%. Actually, most of machines has the software that can determine for you or to you the estimated fetal weight discordance. But if we don't have, we can use this formula, which is weight of the large twin minus the smaller one and multiply in 100. After that, divide on large twin. This formula, you can detect the discordant between both fetuses. Selective fetal growth restriction monochorionic twin is unequal sharing of placental mass and vasculature. In this case, we need to do detailed anomaly scan. If we diagnose selective fetal growth restriction, screening for fetal infection is important, especially cytomegalovirus, rubella, and toxoplasmosis. And amniocentesis is recommended for screening for infection or genetic abnormalities. Screening also depend on the diagnosis of selective fetal growth restriction. is dependent on the combination of measurement of head, biparietal and head circumference, abdominal circumference, and femur measurement to calculate estimated fetal weight. If inter-twin discordance is equal or more than 25%, we should refer to a tertiary center for management and assessment for the plan of management and follow-up. In selective fetal growth restriction, we have 3 types: type 1, type 2, type 3, as you see in image in front of you. And these types depend on the end-diastolic velocity at umbilical artery. In type 1, we have decreased in blood flow, in diastolic blood flow, but still positive. In type 2, we have absent or reversed end-diastolic flow. And in type 3, we have cyclic or what's called intermittent pattern of absent or reversed end-diastolic flow. Not continuous like in type 2. In type 3, it is cyclic and intermittent. The risk of intrauterine death in type 1 is reaching to up to 4%. And in type 2, IUD of either twin up to 29%. And in type 3, it ranges from 10 to 20%. Follow-up of a case of twin pregnancy complicated by selective fetal growth restriction. In case of dichorionic twin, it depends on the severity, but usually we follow the fetuses through fetal Doppler every 2 weeks. If we have a case of monochorionic twin, we follow by fetal Doppler weekly and fetal growth every 2 weeks. Risk of fetal demise of one co-twin before 26 weeks. In this case, it is considered for selective termination of the diseased one. Time of delivery, as you know, it will depend on fetal well-being, interval growth, biophysical profile, ductus venosus waveform, and computerized CTG. We have to know that the respiratory distress syndrome represent about 32% versus 6% lesion, and higher in larger than in smaller co-twin. Death of co-twin represent about 15% in monochorionic twin, while 3% in dichorionic pregnancies. As regard preterm delivery, 68% risk in monochorionic and 54% in dichorionic pregnancies. Abnormal postnatal cranial imaging of the surviving co-twin, 34% in monochorionic twin and 16% in dichorionic pregnancies. As regard neurodevelopmental impairment of surviving co-twin, 26% estimated in monochorionic pregnancy, while 2% in dichorionic pregnancies. In management, it should be at tertiary center, and usually conservative management, because we should know that neurological harm is already or has already happened at the time of death of the co-twin. Conservative management, every 2 weeks, we assess the fetal biometry, umbilical artery Doppler velocity, and middle cerebral artery pulsatility peak systolic velocity. And fetal brain imaging should be done 4 to 6 weeks after death of co-twin. Type of delivery: after course of corticosteroid, it is recommended to deliver at between the age of 34 to 36 weeks. We have a complication of that unique for monochorionic twin pregnancy, which is twin-to-twin transfusion syndrome, twin anemia polycythemia sequence, and twin reversed arterial perfusion. We will see the role of ultrasound in diagnosis and follow-up of these cases. Twin-to-twin transfusion syndrome, up to 1/3 of twin pregnancy are monochorionic, and in nearly all monochorionic twins, the placenta contains vascular anastomosis connecting the two fetal circulation. Monochorionic twins are at risk of developing twin-to-twin transfusion syndrome when there is an equal hemodynamic and amniotic fluid balance. It affects about 10 to 15% of monochorionic twin pregnancies. Untreated cases of twin-to-twin transfusion syndrome, fetal demise in up to 90%, and morbidity rate in survivors of over 50%. Early diagnosis is very important to allow intervention with fetoscope laser ablation. Laser treatment results in 60 to 70% double survivor and 80 to 9% survivor of at least one of them. For diagnosis of twin-to-twin transfusion syndrome, we depend on amniotic fluid volume and the imbalance between the two sacs. The donor, the deepest vertical pool, should be less than 2 centimeters and it considered oligohydramnios, and the recipient, the deepest vertical pool should be more than 8 centimeters to diagnose as polyhydramnios. In Europe, polyhydramnios is different because they classify before or after 20 weeks, and screening should be started at 16 weeks. If you remember in the table, in case of monochorionic, we start from 16 weeks gestational age, and every 2 weeks we follow the patient. Unlike dichorionic, we start at 20 and follow up every 4 weeks. Twin-to-twin transfusion syndrome, we classify the patient or the fetus according to Quantero staging, stage 1 to stage 5. And stage 1, as we mentioned before, the deepest vertical pool for the recipient more than 8 centimeters and for the donor less than 2 centimeters. Stage 2, here the bladder of the donor is not visible on ultrasound. And in stage 3, there is absent or reversed umbilical artery diastolic flow, reversed ductus venosus A wave, and the pulsatile umbilical venous flow in either twin. Stage 4, there is hydrops in one or both. Stage 5 is one or both of them. And the important for staging is for management. In stage 1, conservative management with close surveillance or laser ablation is recommended. Stage 2 and above, laser ablation is recommended. If we are in centers that there is no laser ablation, we can use another methods like selective termination, bipolar dithermy, laser coagulation, or frequency ablation. When laser treatment is not available, serial amnioreduction also can be used, and it is acceptable after 26-week gestational age. As regards follow-up, in this case, every week for 2 weeks, and after that, every 2 weeks. Follow-up will include fetal biometry, deepest vertical pool, umbilical artery, middle cerebral artery, peak systolic velocity, and the ductus venosus assessment. There is recurrence rate of twin-to-twin transfusion syndrome after laser ablation, and it represents about 14%, and the cause here is missed anastomosis. Delivery is recommended at 34 weeks, and post-laser demise of one fetuses. In case of post-laser demise of one fetuses, brain imaging of the surviving one should be considered 4 weeks to 6 weeks later, and neurodevelopment assessment should take place at 2 years of age. We have another complication, which is called TAPS, which is abbreviation of twin anemia polycythemia sequence. Here there is minuscule arteriovenous anastomosis less than 1 millimeter, which allow slow transfusion of blood from the donor to the recipient, leading to high discordance in hemoglobin concentration at birth. The incidence here is up to 5% in monochorionic twin and up to 13% following laser ablation of case of twin-to-twin transfusion syndrome. The diagnosis from 20 weeks depend on the middle cerebral artery peak systolic velocity. The donor, the middle cerebral artery peak systolic velocity should be more than 1.5 multiple of median, and it is a case of anemia. And the recipient, which is there is polycythemia, the middle cerebral artery peak systolic velocity is less than 1 multiple of median. Also, sometimes we depend on placental shape and the natural. In donor, it appears like a bright thickened section, and in recipient, there is towards the recipient there is echo-lucent thin section. But mainly, diagnosis of TAPS depend on the peak systolic velocity of middle cerebral artery. Here, there is a staging of TAPS. The stage 1 depend of depend on middle cerebral peak systolic velocity, as we said. In donor, it will be more than 1.5 multiple of median, and the recipient, it will be less than 1. Stage 2, and the difference between both hemoglobin more than 8. Stage 2, the donor here, the peak systolic velocity is more than 1.7 multiple of median, and the recipient, the peak systolic velocity will be less than 0.8 multiple of median without other signs of fetal compromise. Stage 3, we have stage 1 or 2 plus cardiac compromise in donor or ductus venosus increased or reversed flow. Stage 4, there is hydrops of donor twin, and stage 5, there is death of one or both fetuses. There is 20% risk of neurodevelopmental delay. So brain imaging during third trimester is recommended, and neurodevelopment assessment should take place at 2 years of age. Management, usually conservative management. Sometimes we need for early delivery, laser ablation, intrauterine blood transfusion for the anemic twin, and sometimes we need to do intrauterine blood transfusion for anemic co-twin, and partial exchange transfusion to dilute the blood of the polycythemic twin. But there is no actual or evidence for the management. It depends on the guideline of the tertiary center and the condition of the fetuses. The last one of the major complications that affect monochorionic, which is called TRAP, twin reversed arterial perfusion. And here there is a cardiac mass, like in image B, that depend on the normal bump twin, which is in image A. It is a rare condition and present in 1% of monochorionic twin pregnancies and 1 in 3,500 pregnancies overall. There is hyperdynamic circulation and progressive high output cardiac failure in the bump twin, and the risk of demise of the bump fetus in TRAP sequence managed conservatively is up to 30% by 18 weeks gestation. Management of TRAP to prevent demise of the bump twin and should start before 16 weeks gestation by cord occlusion, coagulation, cord ligation, photocoagulation of the anastomosis, or intrafetal methods such as high frequency or repeat frequency ablation, or intrafetal laser therapy. So at the end, we discussed together as regards the ISUOG guideline of rule of ultrasound in multiple pregnancy. We discussed the dating of pregnancy, determining the chronicity and amnioticity, twin labeling, timing, frequency, and the content of ultrasound assessment. We discussed methods of screening of aneuploidy, for aneuploidy, prenatal diagnosis of aneuploidy, screening for structural anomalies, diagnosis and management of discordant twin, discordant in NET, in CRL, discordant in abnormalities. We discussed fetal reduction and selective termination first trimester and second trimester. We discussed screening for preterm birth and assessment of the cervical length, screening and diagnosis and management of selective fetal growth restriction. And at the end, we discussed diagnosis and management of multiple pregnancy complications that lead to intrauterine deaths, like twin-to-twin transfusion syndrome, TRAP, and TAPS. Thank you for your attendance, and I'd like to share with you some questions. Dr. Saad.
back again. Thanks, Professor Mohamed, for this illustrative presentation. And just little housekeeping before we get started to ask the attendee question to Professor Mohamed. Please, I advise all the attendees to forward their question to the Q&A box. We will try to answer the question, all the question as possible as we can. And the rest will be forwarded to the speakers and the company will get back to you. Professor Mohamed, the first question I have from one attendee, management of twin, one viable and the other is smaller.
Here, according to the chronicity, if we this case is monochorionic, so in this case for termination. If it is dichorionic, conservative management.
And to continue the rest of the pregnancy.
Yes.
Okay, this is some sort of role of fetoscopy in TTS.
Actually, the active management and the important management in TTS is fetoscope for ablation for dividing the placenta to be equal for both of them. So it is very important. It is the major, yes.
I have an interesting question. If we get to screen for trisomy at the booking scan around 13 weeks, and if the results back to us showing abnormal screening results, which one to terminate is a difficult dilemma and the ethical issue. Which one maybe to choose to do feticide if the patient or the family opted to or decided to terminate?
We have discordant abnormalities?
No, just abnormal biochemical screening test for trisomy.
Yes. Here we need first of all to refer the parents and the patient to the tertiary center for counseling the condition. And it depends on monochorionic or dichorionic. And after that, according to the biochemical marker, we can offer for invasive like CVS or amniocentesis or cell-free DNA, and to determine the final situation. And by counseling the patient, usually here the termination will be according to the decision of parents, not doctors.
Another question, can we rely on the cervical length in the first trimester in twin gestations? How much?
In multiple pregnancy, we depend on second trimester assessment of cervical length, and the cutoff at 20 weeks, mostly 25 millimeter is recommended from a lot of guidelines and centers.
So the rule in first trimester is questionable. We have to wait to the end of the second trimester.
Yes.
Is there any rule for 5D in twin anomaly scan?
Actually, 5D is a software, not techniques or not physical ultrasound or related to physics. It is a name for marketing, but it is just softwares. And mainly it depends on or used in cardiac examination, which is used in a lot of companies. So there is no 5D. We can use 2D Doppler and 3D or 4D for anomaly scan. 5D is a software. It has not more advantage than 3 or 4D.
Another clinical question. Date for termination of pregnancy in case of single fetal demise in twin gestations. I think the attendee means when to terminate in case of diagnosing single fetal demise in one of them.
Yes, as I mentioned in lecture, it is recommended at age 34 weeks after corticosteroid administration. And during this period after demise, we follow the living one by fetal biometry, amniotic fluid, and Doppler, umbilical and the middle cerebral. And everything is okay, we can follow and terminate or deliver at age 34 weeks.
34 weeks. One of our attendees asking you to clarify again the T sign and lambda sign, and the best time to elicit.
Okay, the best time first trimester by transvaginal or abdominal transabdominal ultrasound probe. The lambda sign is a fixed, which giving the signs of or the shape of the lambda due to the two amniotic membrane and chorionic membrane, so it appears as lambda. While T sign, which is thin membrane, and at insertion of the placenta, it appears like T because it is the two layers of the amniotic membrane.
The role of Doppler in trap twin. This is another one. Role of Doppler.
Doppler here for assessment or for diagnosis, and just we diagnose one which is a cardiac and the second which is a pumping one. After that, the decision for termination and occlusion of the cord to save the co-twin.
It's a difficult one.
We don't follow. Yes, we don't follow both of them because we fear from hyperdynamic circulation and heart failure.
Another interesting question. One of the attendees asking to give him the presentation of your ones. So this is the job of the Dr. Soha Fargal to get back to the attendee to provide them the materials as they promised.
I can answer him. My presentation is a summary of the guideline. We can send through the organizing company with the certificate. I will send them the guideline for every doctor to review the guideline. I just do a summary of this guideline.
Okay. Can we screen for Edwards syndrome in twin gestation?
I don't understand the question, but trisomy here, we screen for trisomy by and ultrasound.
I think there is a lot more to talk about these hot topics, but since we have paused for time, let us move on to the next station, which is live, or you have to represent again the questions, Professor Mohamed, or?
Yes. Okay, we'll again return back for the post test and the question. The first one.
استاذ احمد، ايه الاجابات بتظهر لهم؟
Okay, thank you for your attendance and for your answering. And at the end of the webinar, we will show you the best answer for the 4 questions. Thank you, Dr. Saad.
شكرا دكتور محمد. Thanks, Professor Mohamed, again, and thanks for the attendee with us. Now, moving to the next station, which is a live demo by Dr. Ahmad Khatib. Ahmad is a senior specialist fetal medicine and ultrasound in Obstetrics, Ain Shams University Maternity Hospital. Also, he is educational committee director for the Egyptian Fetal Medicine Foundation. Let us jump right now to live demo with Ahmad. Ahmad, please.
Good afternoon, everyone. I am Dr. Ahmad Khatib, Senior Specialist of Fetal Medicine and Ultrasound in Gynecology, Ain Shams University Maternity Hospital, and the Educational Director of the Egyptian Fetal Medicine Foundation. I would like to thank you all for being with us today in our webinar with SonoScape, and I would like to thank Professor Mohamed Kamal for his generosity and for his trust for being in this webinar in this demo. Professor Mohamed is well known. He is a professor of Obstetrics and Gynecology, Fayoum University Hospitals, and the president of the Egyptian Fetal Medicine Foundation. I would like to thank SonoScape for supporting this webinar, and as well as the main distributor of SonoScape in Egypt, ESMAR company. We will talk today about the examination, ultrasound examination of the second trimester. First of all, we will talk about the basics of the ultrasound in the trimester, and then we will talk a little bit about the fetal anatomy. When we are using the ultrasound machine, we have to introduce the patient and enter the patient data, the name, the last menstrual period, or any reference date I have. Then I will choose the transducer. Here we will use the curvilinear transducer, the 2D transducer, and the subsettings of the second trimester scan. I want to check the orientation of the probe. The transducer has a knob. This knob represents the knob here in the screen, and the knob of the transducer should be always either cranial towards the patient head or to the right hand side of the patient. If I'm scanning in the longitudinal section, this knob should be toward the patient's head, or if I'm scanning in an axial plane, this knob should be to the right hand side of the patient. I will start in the midline, suprapubic, unfreeze the image, here we can see if the knob is longitudinal, like we are here. So this knob is representing the cranial part, and this side is the caudal part. And this area is the superficial, and then this area is the deep structures behind the uterus. When I'm scanning, I will scan from right to left to assess if we have another presenting port and to assess the fetal count. Sweeping from side to side and sweeping from upside down, we found only one fetus. So the fetal count, then the fetal viability. As you can see here, we have a single and viable fetus. The cardiac pulsation is positive, so I have a single viable fetus. How about the presenting port? As we mentioned before, this is caudal, this is cranial, so the presenting port is the breech. This baby has a breech presentation. And the placenta located anteriorly reaching the fundus. So we have a single viable breech fetus with an anterior placenta, and the liquor looks fine. And I will tell you in a moment how to assess the liquor volume. So fetal count, fetal viability, presenting port, placental site, and liquor volume. Assessment of the liquor volume and the mid-trimester better to be with the deepest vertical pocket method. When we are longitudinal with the transducer, we freeze the maximum or the biggest pocket, then we will measure it perpendicular to the screen as we see here. The normal range is from 2 to 8 centimeters. Below 2 centimeters, this is oligohydramnios, and above 8 centimeters, it's polyhydramnios. Then we will go to the fetal biometry. The fetal biometry, the basic fetal biometry for the mid-trimester, we have to measure the biparietal diameter and the head circumference in a plane we call transventricular plane. The transventricular plane is named so because it's traverse the lateral ventricles, the posterior horn of the lateral ventricles. It should be round to oval with the bone of the skull apparently here all over the head. Rounded to oval, inside the falx cerebri, dividing the brain into 2 equal halves, and the cavum septum pellucidum, dividing the brain to anterior third and posterior 2/3, with the lateral ventricle apparently, or to be more accurate, the posterior horn of the lateral ventricle with the choroid plexus inside. Here we can measure the biparietal diameter, as you can see here, from outer border of the nearest clavarium to the inner border of the farthest clavarium, perpendicular to the falx cerebri in the widest diameter. Then we can measure the head circumference. The bone all around will be measured, as we can see here. So it's mostly compatible with the gestational age. Then if we want to measure something else in the head, this would be the transcerebellar diameter. The transcerebellar diameter is important in the mid-trimester as it is the most accurate parameter in assessment of the gestational age if we have a normal fetal head and brain. If we incline the transducer postero-inferior in the fetus, like we see here, from the transventricular plane, we will find the posterior fossa and we can measure the transcerebellar diameter as we will see here. The transcerebellar diameter should be measured from outer to outer, perpendicular to the worms in the widest diameter, like so. And roughly in millimeters, it's equal to the gestational age in weeks. Then we will go further down in the fetus, in the axial plane, to find the 4-chamber view plane. Then if we go down the 4-chamber view plane, we will find the optimum plane for abdominal circumference measurement. It should be circular, as we can see here, and the anatomical landmarks will be the spine posteriorly, the anterior abdominal wall anteriorly, with the main liver lobe on the right side and the stomach on the left side. Here we will measure the abdominal circumference like so, and the skin of the abdominal circumference is included in the measurement in order to have an accurate assessment of the abdominal circumference. Then we will go down in the fetus in the same axial plane to reach the pelvis. Here we can find the bladder, the urinary bladder, an echo-free circular area in the lower portion of the pelvis. And if we turn on color, as we can see here, we will find that the umbilical arteries running around the urinary bladder. Then we will find the iliac bone, and beside the iliac bone, as we can see here, a cut section and a single bone beside the pelvis, which is the femur. If we make a rotational movement, as you can see here, we will bring the full length of the femur. And to measure the femur accurately, we have to have the femur as much as we can parallel to the ultrasound angle. If it have a degree of inclination, it shouldn't be more than 45 degrees. The femur shouldn't be interrupted. The full length of the femur should be apparent, as we can see here. And we should have a soft tissue above and soft tissue below the proximal and the distal metaphyses consecutively. The measurements of the femur, in order to be accurate, we'll measure it from the midpoint of the proximal to the midpoint of the distal metaphysis. Here we have measured the whole basic fetal biometry in the second trimester. We will revise our measurements in order to know the fetal growth or the fetal weight assessment and the other parameters. Is it compatible with the provisional gestational age we have by the menstrual dates or not? It's compatible. For the weight, it's compatible. And we have an option to see the graph. As we can see here, each parameter in the report can be demonstrated on the graph. It's compatible with gestational age for each one. We will go faster through the fetal anatomy. The brain fetal anatomy we mentioned in the biometry of the head that we have to see the falx cerebri, the cavum septum pellucidum, the lateral ventricle with the choroid plexus inside, and posteriorly we will see the cerebellum and the cisterna magna, and we can measure both of them. If we rotate the transducer, we can bring the parasagittal plane. And if we rotate the transducer on the opposite side, we can see the coronal plane of the head and face. As we can see here, we can see the high coronal plane with the orbits and the maxilla. And if you go down, we will check the lower coronal plane, which examine the lips and the nostrils. Further down, we can get the sagittal section of the spine, demonstrating the ossification centers of the spine, as well as the overlying skin. Here is the lungs. And if we have a cut section in the thorax at the level of the full chamber view, we can assess the full chamber view plane. It's better for sure to assess the fetal heart in a different settings. And you will find on the transducer, when you choose the software you are using, that there is a preset for the fetal heart examination, which could be better for scanning the fetal heart. As you can see here. Then we will return to the sagittal section. Going down, check the kidneys on both sides of the spine, as you can see here, and in the cut section. You will find the stomach on the left side beneath the diaphragm, and the urinary bladder is properly filled with the umbilical vessels running around. The umbilical cord insertion is normal. The limbs have 3 segments, as you can see here. The upper limb humerus, proximal segment, middle segment, radius and ulna, and the hand, with a normal relationship between the forearm and the hand. The lower limb, this is the femur, the proximal, tibia and fibula, the middle portion, and the foot. These are the 3 segments of the lower limb, with a normal relation between the foot and the leg. If you want to perform the Doppler assessment of the uterine artery, just go to the iliac fossa and turn on color, searching for the iliac vessels, and then you will find the uterine artery crossing the iliac vessels, as you can see here. The umbilical artery Doppler should be done in a free loop, which is away from the fetal end of the umbilical cord, away from the placental end of the umbilical cord. Then after you turn the color, you will turn on the pulsed wave, adjust the sample volume, and then hit update or set. Then you will acquire the wave. You have to have 3 successive similar waves in order to have an accurate results of the umbilical artery blood flow. And last but not least, if you want to check the ductus venosus blood flow, you have to follow the umbilical vein till it reaches the inferior vena cava. Turn on the pulsed wave, adjust the sample volume, then you will acquire the ductus venosus blood flow. If we want to have a volume, we will change the transducer to the volumetric transducer, then choose the second trimester subsection, activate the 3D, 4D button. This sample volume box, the volume box will be apparently on the screen. Then you will adjust the volume box to the region of the interest you want to have the volume. The face to be examined in the coronal plane, you have to bring the parasagittal plane or the profile, then adjust the camera line over the face with a rim of amniotic fluid present in front of the face. Then you will acquire the volume like so. You may need to invert the image upside down. Then manipulate the XYZ to reach the optimum image of the fetal face. You have a different maps like this one, this one, we had a volume with automatic face detection, this one, which removes any noise, any unnecessary structures in front of the face. If we want to take a volume for the spine, we have to have the spine in a sagittal section like so, then activate the volume. The volume box should be adjusted to get the spine. I have to use the skeletal mode or the maximum mode. Then the camera line should be parallel to the spine, as we can see here. Then we will hit acquire or update. You may need to invert the image upside down. As you can see, the spine here in a 3D reconstructed image. You can also use the multiplanar. To see the 3 ossification center in each level. Thank you very much. Thank you for now. We'll see you soon. Bye-bye.
Welcome back again. As promised in the beginning of this webinar, to present an interesting hot topics by eminent speakers. Now, without further ado, I'll turn the time over to Dr. Heba Mahdy. Dr. Heba is a consultant OB/GYN who had a special interest in the discipline of fetal and maternal medicine. Dr. Heba graduated from Alexandria University, Egypt, and she had her postgraduate training in Saudi Arabia, where she worked in well-renowned institutions like King Abdulaziz University in Jeddah, National Guard Hospitals in Al-Khobar. She attained her MRCPI from the Royal College of Physicians of Ireland in 2015. She had a special interest in medical education and research, and she attained a postgraduate degree in the Global Health Education Initiative from the University of Toronto, Canada, 2021. She holds the position of Managing Chief Editor in the StatPearls Publishing, Florida, USA, and she was a reviewer to ISUOG UK in 2021, and in renewed journals, The Placenta. She currently works as a clinical fellow in advanced obstetrics at Mount Sinai Hospital, Toronto, Canada. Dr. Heba will talk to us about the recurrent pregnancy loss contemporary perspective. This presentation will take about 40 minutes, and we have allocated 2 minutes for the attendee to send us their question in the question and answer box. We have allocated 10 minutes to answer some of these questions, hopefully all. If you are not speaking, please put yourself in mute. And if you feel the sound quality is poor throughout the presentation, don't hesitate to contact us for technical issue. All right, let us dive right in with Dr. Heba, please.
Hello, everyone. Thank you so much for inviting me for this wonderful webinar. I'd like to thank the Egyptian Fetal Medicine Foundation and SonoScape company for sponsoring our event. Special thanks for Pure Spot and all the people working behind the scenes. I'm going to start my talk today talking about a very important and challenging topic. It's recurrent pregnancy loss. So first, I have a disclosure. I don't have any actual or potential conflict, but this webinar is sponsored and financially supported by the SonoScape company. So the objectives of my talk today is to review the established and the controversial etiologies of the recurrent pregnancy loss, to discuss the recommended therapeutic strategies with a special focus on the unexplained recurrent pregnancy loss, discuss the current empiric treatments, and shed lights on aspects of management of this very challenging topic. So hope you enjoy my talk, but I'm gonna start with a challenge. It's a pre-test. It's not painful, it's brainstorming, so please be ready to the first question. So this is a scenario. I could read it for you, and it's written in front of you. She's a 25-year-old G3 para0 +2, pregnant and 9 weeks of gestation, presents to the eMERGE complaining of vaginal bleeding for the last 24 hours, and she had a positive pregnancy test 4 weeks ago. The episode stopped by the time she arrived at the hospital. A serum beta HCG is negative, while an ultrasound reveals an empty gestational sac. While the provider sensitively informs her that the pregnancy is no longer viable, she breaks into tears and she asks what could have caused it, as she was very meticulous about all the precautions that were given for her at her first prenatal visit. Which of the following is the best explanation for both conditions? You have one of 4 options. Please select one. I think I'm the one who will. I thought it's gonna come automatically, but I think that's enough time for the first question. So I'm gonna move for the second one. So the second scenario is about a 28-year-old lady who presents to the clinician for evaluation of recurrent pregnancy loss. She had 2 miscarriages since she had been trying to have a baby 2 years ago. She has no known medical problems, although she did have a blood clot in her leg while taking the OCPs 5 years ago. Physical exam shows a model reticular vascular pattern on the legs bilaterally. Which of the following is the best initial test to diagnose the underlying condition? You have 4 options, and again, it's one option. So I'm gonna move to the third scenario. It's about 32-year-old G5P0 at 10 weeks gestation presents to her provider as she's concerned that she would never be able to carry a baby to term. And she reports having a history of previous 4 recurrent miscarriages, sadly at 8, 10, 12, and 14 weeks of gestation successively. She reports that she underwent exhaustive laboratory workup that does not reveal a single abnormality. Her provider requests a pelvic ultrasound scan that's also unremarkable. Which of the following is the most appropriate test in this woman? So let's move to this. 28-year-old at 19 weeks gestation presents with severe pelvic pain and vaginal bleeding for the last 2 hours. Her past obstetric history is significant for 2 miscarriages. Pelvic ultrasound reveals a gestational sac 28 millimeters in diameter with no obvious yolk sac and no signs of fetal cardiac activity. Uterine anomaly is also present. Which of the following is the most common uterine anomaly that causes recurrent pregnancy loss in this patient? Moving to the last scenario, 36-year-old female presents with a recent history of spontaneous miscarriage. She has a history of 3 recurrent spontaneous miscarriages in the past 3 years ago, and she also has a history of a blood clot in her left leg while she was on OCPs 5 years ago. She reports a positive family history of recurrent DVT in her mother. She states that she's a smoker and smokes about 1 to 2 cigarettes per day. Her physical exam is unremarkable. Which of the following underlying etiologies is most likely responsible for her condition? So this was like an intense pre-test. We're gonna do it again after my lecture, so you're gonna understand the difference if you are paying attention during my talk, so please pay attention. I'm gonna start with the definition, and I believe that recurrent pregnancy loss is a problem because it doesn't have a consensus on the definition. So you're gonna find many well-renowned institutions around the world define it differently. For instance, we start with the RCOG UK in 2011, and they didn't update their guidelines since then. They define it as the occurrence of 3 or more consecutive pregnancy losses. So 3 consecutive pregnancy losses is defined by the RCOG as an RPL. The American Society of Reproductive Medicine, they produced a clinical practice guideline that has recently redefined the recurrent pregnancy loss as 2 or more pregnancy losses. And if, like here, I want you to pay attention that the RCOG, they define it as 3 consecutive. They have to be repetitively. And the ASRM, they define it as 2 or more pregnancy losses. And they didn't count if they are successive or not. Actually, there is no definition to the non-successive pregnancy losses. But I'm going to tell you about this in a minute. So a pregnancy loss is defined as a clinically recognized pregnancy involuntarily ending before 20 weeks or before 24 weeks if the age of viability in the UK, for instance, it's 24, not 20. In North America, it's 20 weeks. But the point here is that I want you to understand there is a difference between the biochemical pregnancy and the clinically recognized pregnancy. So clinically recognized pregnancy is when the pregnancy has been visualized either on ultrasound or you obtain a pregnancy tissue and you send it for histopathology and you identify the pregnancy on it. So if you have an ultrasound diagnosis or a histopathological diagnosis, this is a clinically recognized pregnancy. But if the woman loses the pregnancy before an evidence of this pregnancy, either by ultrasound or biochemically, it won't be counted into the number of the spontaneous losses or the recurrent pregnancy losses that she's having. So this is a bit confusing when you're taking history. If you don't pay attention to this, you're gonna say that the woman has a recurrent pregnancy loss where she, for instance, lost 2 chemical pregnancies, biochemical pregnancies. So it's not a recurrent pregnancy loss. It doesn't fit into the criteria for diagnosis. Other classification that they classified into primary, secondary, and tertiary, and they refer to the primary RPL as multiple losses in a woman with no previous viable infants. So the woman tends to lose babies, but she never ended in a live birth. This is a primary RPL. The secondary RPL refers to multiple losses in a woman who has already had a pregnancy beyond 20 gestational weeks. What about if she has multiple pregnancy losses between normal pregnancies? So she has like 2 or 3 liveborns and she had multiple pregnancy losses in between. This is what we call the tertiary RPL. So how common is it? The coded incidence is very variable. That's why there is no agreement, no consensus agreement on the definition. You're going to find the incidence is different from study to study, but only about 2% of the pregnant women have 2 consecutive pregnancy losses. So I put this slide here, and I'm going to say that what are you trying to tell us here? What I'm trying to tell you here, I want you to differentiate the sporadic pregnancy loss from the recurrent. And the idea is the soil and the seed. So you have the soil, you have the seed. You have the soil, it's the uterus, it's the endometrium. And this is the fancy term of endometrial receptivity. So people that they don't understand what we refer to endometrial receptivity, it's the soil where the seed, which is the embryo, will implant. So with the sporadic pregnancy loss, I want you to think of defective embryo. So the problem with the spontaneous would be the genetic makeup of this embryo is not really correct. This is an incompetent or a defective embryo. That's why the pregnancy does not continue. While in recurrent pregnancy losses, the scenario is different. It's the soil, it's the endometrium, it's the immunological factors, it's the other factors, or sometimes it's even unexplained. So sometimes we don't know what's the reason for this lady. She's not holding up a baby. So here I put a slide for the etiology of the RPL, and you could see that sadly 50% of the causes are unexplained. And that's another challenge that makes this topic is really difficult. We do have 20% of the causes in the anatomic factors. I'm gonna speak about each point in details. We do have other factors like endocrine factors, immunological factors, genetic infections, or as I mentioned, the big challenge when we don't have any of those, because it's easy when you investigate and you know your workup and you find the cause. You're going to find this in 50% of the case. So all what you need to do is just to be aware of what are the causes that are known for the RPL, and just request the investigations and do the procedures to prove that there is a reason. That if you find the cause, you're going to treat it. But the challenge comes with when we don't find the cause to treat it. That's why we try to be like trying everything, because we're desperate and we want to help our patients. So that's also an important question, because it says that, can we predict the cause of RPL depending upon the week of gestation? So if the woman tells you, I miscarried at 6 weeks, 7 weeks, 8 weeks, or I miscarried at 12 weeks, or I tend to miscarry in the second trimester, would it make a difference in terms of the etiology? The answer is yes. So if the woman miscarries a baby pre-embryonic, the common causes would be the idiopathic, the chromosomal, and the hormonal. But in the embryonic period, which is defined between 6 and 8 weeks, also the causes would be the same: idiopathic, chromosomal, and hormonal. For the fetal pregnancy loss, which is defined as if the woman loses a pregnancy after 8 weeks, so she comes in, she lost a baby at 9, 10, 11. The common reason you're going to think about antiphospholipid antibody syndrome, and I want you all to be vigilant for this and do the investigations early. Don't let her lose 2, 3, 4. Then you come and think, oh, I didn't do antiphospholipid. And at the end of the day, she's antiphospholipid syndrome, because it's easy when we find antiphospholipid, we're going to treat it. There is a treatment. This is different than if the woman tends to lose a baby in the second trimester. Anatomical factors comes first, plus hormonal, and it might be other factors. And sometimes it's not only one factor that's controlling the process. Sometimes it's integration of multiple factors that are responsible about the pregnancy loss. So this is a nice curve. It's actually, if you go to any infertility clinic in Canada, or I believe in most of the Western world, you're going to find this curve in the clinic. We show it to the woman and we tell her, because this is the prevention, this is the education. You tell her that the age is an independent risk factor for the recurrent pregnancy loss. I can't help it. So you need to think about your fertility early, because they are fertile when they start, like if we say they start sexual activity, let's say at around 20. I know that this is not the case here in Western countries, but let's say she starts to think of having a family at this between 20 and 30 until 35, that's fine. 37, 38, 39, it comes the problems. There is an increase in the rate of the pregnancy losses with increasing age. Coming to 40 years, the risk of miscarriages is 40%. If she hits 45, it's 60%. And it makes sense, because like here in Canada, for instance, we put the age that we will do an IVF for women, it would be until 43-year-old, because we believe that doing it after 43 is not really beneficial. So there are many factors for the woman, unless they do here that the woman has the womb already and the uterus is ready, so she could do donor oocytes. But I believe that there are a lot of religious and other factors into this. So not all the countries are following the same protocols or accepting this. It's very prohibited, especially in the Muslim countries. So recurrent pregnancy loss and the paternal age. So the risk of miscarriage is highest among couples where the woman is 35-year-old or more, and the man is 40-year-old or more. This is important because when you want to counsel your patients, you want to tell them, like, right now when a young woman comes in and she said, like, oh, but I'm in the university right now, I'm doing my postgraduate training, I'm a doctor, for instance, I'm a gynecologist, and I want to do my boards, and I'm going to delay this. And I got married to a man who is like 5 or 10 years older than me. So they are delaying conception, and they didn't know this simple fact. So this simple curve that I showed to you, it should be in every infertility clinic or every physician who is counseling patients about the infertility in general or about pregnancy losses. You need to tell them that the age is an important factor. Let's go for a very important cause of the recurrent pregnancy loss, which is the anatomic causes. We do have congenital Mullerian tract anomalies in the form of septate uterus, unicornate uterus, bicornate uterus, uterine didelphys, and arcuate uterus. And let me tell you something. I agree and I believe in hysteroscopy and the role of hysteroscopy and how this modernizes our practice. But I don't believe that if you find a septate uterus and a woman who miscarried a baby in the first trimester, that you're going to attribute this to the septum. Please refrain from doing this. If you find the septum, the septum might be responsible, or yes, I would believe it's responsible about a miscarriage that happens in the second trimester, or a miscarriage or a preterm delivery, for instance, is caused by the septate uterus. But this small, tiny septum in the uterus in the first trimester, when the woman keeps to losing a baby at 8 weeks, 9 weeks, 10 weeks, it's not the cause of the septate uterus. I did many C-sections on patients where I find the woman having a uterine didelphys, even unicornate or whatever, and it wasn't diagnosed before. She comes in pregnant. She's now in the OR, and I'm doing the section, and the septum doesn't interfere with the implantation, and it doesn't interfere with anything. I don't say this like as a matter of a personal opinion, but the studies are proving this, and we don't have a consensus recommendation that every single woman who is desperate to know her reasons. Sometimes you miss up on important reasons like immunological reasons or whatever the reason underlying one, and you go and you just detect a tiny, tiny septum, and you say that go for hysteroscopic resection. You let them pay a lot of money that sometimes they couldn't afford, and they feel bad about it, but sometimes they are desperate. They want to do whatever it takes in order to get a baby. So keep this in mind. The cervical incompetence also is a very important risk factor also for the second trimester. And you know the role of cerclage and everything about second trimester losses. I don't go for discussion about this. I would just focus about the other causes because the talk is really very long one, so I want to make it shorter. The anatomic factors, as I mentioned, hysteroscopy and laparoscopy is a gold standard in the Mullerian or any anatomical or structural defects within the uterus. Sonohysterography is really nice, especially in the low resource settings when they don't have an access to hysteroscopy, or it's difficult to do a referral, or it's expensive. So hysteroscopy and 3D ultrasound have more than 90% efficacy. So don't feel bad if you don't have hysteroscopy or if you don't have the surgical skills to perform the procedure. Hysteroscopy is very nice when it comes to see and treat. That's why even if you diagnose on a sonohysterogram or you diagnose on 3D ultrasound because you are in a rural area or remote area and you don't have a hysteroscopy, send it to the proper person. Send it to the one who have the surgical skills and the training to do it. Don't just because you want to learn. There are simulation centers. There are a lot of ways in order for us to work as a group to enhance education. But don't operate on a patient, who is very desperate to have a baby, and you do something like hysteroscopy for her where you don't know how to do hysteroscopy, and you let her end up with Asherman syndrome or a lot of problems or adhesions or pain or whatever. Or it might be even the workup I'm giving you today, the juniors among us attending, please refer those patients to the specialized ones. Go to those specialized centers and train with the senior ones. Then you would be capable to deliver the best standard care of your patient. So again, the septum, the myoma, the Asherman, you could do septum, you could resect it hysteroscopically successfully in good hands, only if you are trained to do so. Myoma also could be done through hysteroscopic myomectomy. Asherman syndrome, we do have wonderful surgeons who have the surgical expertise in hysteroscopy, and they could manage those cases and give them a great outcome. So the environmental factors, do they play a role in the recurrent pregnancy loss? That's very important. And I put this slide early on, although environmental causes are not like the most common or anything, but I just put it because I am very keen that you counsel your patient properly. So when a patient comes into you with a problem like the RPL, you need to talk to her about smoking. So the evidence is saying that the maternal caffeine cigarette and caffeine consumption have been associated with an increased risk of spontaneous miscarriage in a dose-dependent manner. But listen, smoking and caffeine consumption does not increase the risk of recurrent pregnancy losses. It increases the risk of sporadic But it's a good practice to tell any woman comes to your clinic that please stop smoking, refer her to smoking cessation programs if you have one, and encourage her to not to drink a lot of coffee. So the evidence is saying that the maximum a woman is thinking to become pregnant, or a woman with RPL wants to become pregnant, or even a pregnant woman wants to ask you about the advice, not more than maximum 2 cups of coffee a day. So they found that more than, like, if she hits 3 cups of coffee a day, definitely there are problems for her fertility, even when she's pregnant later on. Again, the same advice for alcohol. Why? Because we don't know the safe limit of alcohol consumption. So we as physicians, we are not aware what's the level. We should tell her, drink a glass, 2, 3, we don't know. Sometimes even if they take a sip, it causes problems. So that's why we say refrain from alcohol if you're thinking and if you're having RPL and you want to. I put also here the airports. Women nowadays, we are in the area where women are strong and they work in different jobs they didn't tend to do in the past. One of them is working in the airports, being screened by the video machines every day, and the X-ray exposure during the long haul flights. So all of this, it might be a factor, but it's not proven that it causes recurrent pregnancy losses, but it might be a factor. So you need to tell the woman, you need to have a discussion about her. What about women who works in healthcare, like us? If a woman works in a hospital setting, if she's a nurse and she works in a hospital, you need to tell her that there are some risks related to the anesthetics, some risks related to the exposure to radiation, and this might affect the RPL. But this is also, the evidence is very, very limited and it's not strong enough. Cervical insufficiency or incompetence. Currently, there is no satisfactory objective test to identify women with cervical weakness in the non-pregnant state. That's unfortunate, because we will tend to wait until the woman becomes pregnant, then eventually the cervix becomes shorter. Then she comes to you and you are either she will end up with a cerclage or she will end up with a pregnancy loss. So the diagnosis based on a history of a second trimester miscarriage preceded by spontaneous rupture of membranes or painless cervical dilatation. And this is quite common scenario when the woman sometimes, like, she will come to you, she said, like, this would be very, very quick. The cervical insufficiency, everything would be okay until a point she will phone the emergency because she lost the baby story in the toilet basin, you know? So this is the kind of history that you are looking for. So this is the previous slide I was looking for. This is the effect of the anesthetics on the recurrent pregnancy loss. So obesity and RPL. The evidence is saying that obesity is an issue. That's why we tend to tell women that please reduce your weight. Reduce your weight if you want to become pregnant. Reduce your weight if you want to be treated. Reduce your weight if you're going for an infertility clinic. Reduce your weight definitely if you have a recurrent pregnancy loss. So this is very important. Let's come to one of the most important conditions that's easy, I would say, to treat, because the treatment is very straightforward. You just need to diagnose it. You just need to be aware that this is a reason of recurrent pregnancy loss. This is the antiphospholipid syndrome. So it's the most important treatable cause of the recurrent miscarriage. Antiphospholipid syndrome refers to the association between antiphospholipid antibodies, lupus anticoagulant, anticardiolipin antibodies, and beta-2 glycoprotein 1 antibodies, and adverse pregnancy outcome or vascular thrombosis. So this is a woman that will come to you with either vascular thrombosis and a laboratory evidence of one of those, or the 2 of those, or 3 of those. But the idea is saying that you're going to find the antibody would be an IgM or IgG, it would be more than 40, and you should repeat the test in 3 months. So one single test is not enough to diagnose the woman as antiphospholipid syndrome. It has to be, if you find a woman having any of those antibodies in a laboratory test, you need to bring her back in 3 months and repeat the test. And if the test is confirmed for the second time positive, this is a woman, you tell her that you have an antiphospholipid syndrome based on the biochemical and one of those, biochemical plus adverse pregnancy outcome, or biochemical and she had a vascular thrombosis, because these antibodies tend to cause vascular thrombosis. What are the adverse pregnancy outcomes we are looking for? We are looking for either 3 or more consecutive miscarriages before 10. This is a woman that lost the baby at 6, at 8, at 9 weeks, or 1 or more morphologically normal fetal losses after the 10th week of gestation. 1 or more preterm birth before the 34th week of gestation owing to placental disease. So these are the adverse pregnancy outcomes you're looking for, plus the laboratory evidence confirmed on another test 3 months after the first one to diagnose antiphospholipid syndrome. And if you do, you need to initiate the treatment. Treatment would be low molecular weight heparin because it's effective, and the mechanism of action would be inhibition of the trophoblastic function and differentiation, activation of complement pathways at the maternal fetal interface, resulting in a local inflammatory response, and later in pregnancy, thrombosis of the uteroplacental vasculature. So you need to give her the low molecular weight heparin. I put here 3 for the common ones. So the clexane is the enoxaparin, the fragment is the dalteparin, and the enohap is the tenzaparin. Because in the guidelines, they won't try to use those company names because we are not promoting for anyone here. We're just saying evidence. So clexane is the low molecular weight heparin, enoxaparin. That's the most commonly used, but some centers you're gonna find dalteparin or the inohap, which is the tenzaparin, and you need to be aware of the dosage schedules for each of those. You combine it with aspirin. So if you find a woman and you diagnose a woman with antiphospholipid syndrome, you give her aspirin, you give her clexane, and you continue to do this to prevent her risk and let her become successful in getting a baby. Let's talk about another issue, which is the inherited thrombophilia, like the protein C deficiency, protein S deficiency, antithrombin 3 deficiencies, and the homozygous or heterozygous factor V Leiden, for instance. So these are called inherited thrombophilias. The routine testing for women with RPL for inherited thrombophilias is not currently recommended. So please don't screen them routinely just because she had a recurrent pregnancy loss. Antiphospholipid, I told you yes, if she has the criteria I mentioned. But routinely for inherited thrombophilias, no. And it could be clinically justified when a patient has a personal history of venous thromboembolism in the setting of a non-recurrent risk factor. And what we mean by non-recurrent risk factors, such as a surgery. She had the surgery, like she had a fracture, she went to the orthopedic surgeon and she was admitted in the hospital, she got a DVT and she was treated. So at this case, yes, go and look for thrombophilias. First degree relative who has a known or suspected high risk thrombophilia. This is indicated to screen for the thrombophilia. Genetic causes of RPL. We come to the genetics. I know that you don't like the genetics that much, and I'm so sorry to hear that, but it's important factor in the recurrent pregnancy loss. So we do have something, what we call balanced translocations. You remember, I won't take here much about the problems with the baby in terms of the problems with the chromosomes of the baby, because as we mentioned earlier, that if it's a recurrent pregnancy loss, the cause is in the soil, and the soil, it might be related to the genetic translocations in the baby. It was like 75% in the soil and 25% in the baby. Those 25%, it tends to be balanced translocation. And what I mean by balanced translocation, as in here, there is a chromosome, there is another one. The patient didn't lose any chromosome materials, but it was translocated to another area. So at the end of the day, she has the same amount of the chromosomal materials that she should have, but there is a translocation of one of the chromosomes on other. So if you find this is what we call it balanced translocation. So if you find the autosomes exchange pieces between the chromosomes, this is a balanced translocation. And let me tell you this because I know that some people are confused about the balanced and unbalanced translocation. What will happen that, for instance, I have a balanced translocation. You wouldn't know anything about me that I wouldn't look weird. I wouldn't look different. I'm a normal person living among you, and I have a balanced translocation. What happens that if I am with a man who has a balanced translocation and he's a totally normal man without any problems, and we marry, we get a baby, this baby we start to have recurrent pregnancy loss, we're going to do analysis of the conception product, and we found this baby has, when we test the products, we found that the baby has unbalanced translocation. So we didn't have unbalanced, that's why we are normal. So, but we have the material not in the proper place, but it's there. But for the kids, the baby, no, they have the unbalanced translocation where they lost some of the genetic materials. That's why this is the reason of recurrent pregnancy loss in terms of the balanced translocation. I hope this clarifies this point because it's important. So embryonic chromosomal abnormalities, if the genetic makeup of the baby is not good, there is a risk of miscarriage resulting from abnormalities of the baby that increases with advancing maternal age. That's why we want to tell women that don't delay pregnancy very bad. Like don't delay it until 38, 39, 40, 42, 43. Then you come and say, I want a baby. Even if you think that ART technology is helping us, but it doesn't help the age. Still, there are problems because of the maternal age. So let's talk about cytogenetic analysis of the products, retained products of conception. The cytogenetic analysis should be performed on the products on the third and subsequent consecutive miscarriages. This is like, some of you would ask me, like, the woman, she loses already 3 pregnancies and you want me to do cytogenetic analysis of the retained products of conception. I personally would say that if you have like a woman who is like 38, 39, and she has like 2 recurrent pregnancy losses until now, so please send the products of the conception for analysis, because she might gain information out of this. And it's not that difficult or it's not that expensive to wait until the 3rd miscarriage. I know that the evidence is controversial in terms of the grade of recommendation, but there are common sense for the best interest for our patients. What about the parental peripheral blood karyotyping of both parents? It should be performed in couples when the testing of the products report unbalanced structural chromosomal abnormality. This is, again, according to RCOG UK, they follow this, but in other areas of the world, they tend to do the karyotyping early and do the cytogenetic analysis early. And I'm telling you, this area of reproductive endocrinology and infertility, the practices vary from one institution to the other. So you're going to find discrepancies between the ISHRI, between the ASRM in the US, between the RCOG, between the other respected bodies all over the world. So this is a kind of topic that if you find one of your colleagues doing something different than whatever you're doing, because the literature is equivocal. So the endocrine factors, this is very important. As we mentioned about obesity and optimization of the body weight, there are endocrine factors that might contribute, like diabetes. Diabetes is a pandemic right now, and thyroid disease also, we see many thyroid disease problems in women. So it tends to be associated with miscarriage only if it's uncontrolled. So if you see a young woman who has a recurrent pregnancy loss, or she has infertility and she seeks to become pregnant, please optimize their blood glucose. Please optimize their thyroid hormone levels. And this area in recurrent pregnancy loss, they find that it's not necessarily the thyroid levels, because like, what are you going to do? You want to screen a woman for hypo or hyperthyroidism, you ask for TSH. TSH should be your primary test. If you are in a center where you are okay to request investigation, you could request the T4. So these are the only 2 investigations, TSH and T4. Ideally, you should request TSH only. Then according to the TSH, it gives you an idea about the thyroid hormones. So TSH, T4, and you diagnose. What about if you feel like if you find a result where the TSH exceeds 2.5? You need to do the TPO antibodies. So you do the thyroid antibodies when you suspect, because they said, like, even if the woman with normal thyroid levels and they do have antibodies, the evidence is not telling us a specific recommendation for these women. But I think it's worth trying something for those women, because they tend to miscarry, and even if they are euthyroid, because if you give them eltroxin or synthroid, whatever its name in your country, you're going to replace the deficient hormone. But there is no evidence to do this with the subclinical hypothyroidism. That's why I'm telling you, for those women with subclinical hypothyroidism, the evidence is equivocal. With those women with the thyroid antibodies, some of the guidelines are saying that look at, it's a combined factor, look at the endometrium and the problems within the endometrium. I'm so sorry, this is the ambulance in the hospital. That's bad. So yeah, let's go back. I'm so sorry for that. So the thyroid antibodies, as I mentioned, it has its importance, and it will differ from one area to the other because the prevalence of the disease in the population you're working for. Hyperprolactinemia and RPL. So it's associated with infertility, and we know it's associated with miscarriage by altering the hypothalamic pituitary ovarian axis. This would lead to impaired folliculogenesis and anovulation. Treatment of the underlying cause restores normal fertility. That's why prolactin level is one of the important and mandatory investigations in any infertile couple coming to you, right? So for women with idiopathic hyperprolactinemia and RPL, where you don't find the reason for the hyperprolactinemia, what they said like they did a one small RCT, randomized controlled trial, and they found that dopamine agonists in the form of bromocriptine at a dose of 2.5 to 5 milligrams per day until the 9th week of gestation significantly decreased miscarriage rates compared to no treatment. But let me tell you that the number of this study is small. So it's difficult to draw a conclusion here. The live birth rates, however, it was comparable. So it doesn't improve the live birth much. PCOS, very important topic for the infertility problems and again in recurrent pregnancy loss, and it has been linked to increased risk of miscarriage, but the exact mechanism remains unclear. So the increased risk of miscarriage in women with PCOS has been attributed to the insulin resistance, the hyperprolactinemia, the hyperinsulinemia, and the hyperandrogenemia. And the hyperinsulinemia is very important. So the prevalence of insulin resistance is increased in women with recurrent miscarriage compared with their matched fertile couples. And an elevated free androgen index appears to be a prognostic factor for a subsequent miscarriage in women with recurrent miscarriage. So please request the androgen-free index for PCOS women. Don't depend only on a single reading of testosterone. So immune factors. Let's come again at the area that you might not be, quite comfortable reading about this, but it's really important. This is a review article from the American Journal of Reproductive Immunology. It was published recently in February 2021. It talks about the role of lymphocyte immunotherapy in recurrent miscarriage and recurrent implantation failure. And let me tell you about this. Recurrent implantation failure we refer to as RIF. Recurrent implantation failure we refer to when we do an IVF cycle and the baby fails to implant. This is a recurrent implantation failure. It should be another talk if you want to talk about this because it has its own mechanisms and strategies to manage. So in the vast majority of studies, the use of the lymphocyte immunotherapy for recurrent miscarriage has shown an improvement in pregnancy outcomes. And the most of the current studies that support the evidence are quasi-experimental with few randomized double studies. However, the current evidence are not convincing for the use of them like routinely in the patients. But the problem with the recurrent pregnancy loss that we don't have enough clinical trials. And let me take the opportunity out of this talk and tell you that we should raise our level in the research. We should register our patients. We should do clinical trials because that's the only way that we're going to change evidence and we improve our understanding of challenging conditions like RPL. So research plays a crucial role in this aspect. The alloimmune causes, while the fetus does exist in a relatively immune privileged state, there are inflammatory responses. And inflammation, I'm telling you, is the underlying mechanism of most of the diseases right now. Even diabetes, people, they believe that diabetes, the underlying mechanism of type 2 diabetes is an inflammation happening. Even PCOS, there is an inflammation happening. So recurrent pregnancy loss, inflammation plays a major role. So it must occur at the appropriate time and the strength for the human implantation to occur. There are components of the immune system that can either promote or suppress the trophoblast implantation. And the entire state of the pregnancy is in fact pro-inflammatory. We know this. once the woman is pregnant, she's in a pro-inflammatory state. And this would be elevated during the pregnancy, including all those factors, TNF, alpha, tumor necrosis factor alpha, interleukins 1 and 6 and 10, along with reduced levels of the interleukin 2. So these changes are thought to be mediated by estrogen and progesterone. While estrogen is pro-inflammatory, progesterone is thought to be immunosuppressive. So this is the normal balance that happens in order to balance things up during the pregnancy. The natural killer cells. This is very important, and I put here a slide for you just to give you an understanding about what is a natural killer cells. Natural killer cells, we do have it in the uterus, and we do have natural killer cells in your bloodstream. So we could measure it from the uterus or measure it from the bloodstream, but actually measuring natural killer cells in the uterus is daunting. It's very difficult, and it's only done under research or clinical trials, and it's not applicable in life. What we do is peripheral natural killer cells, and I'm going to tell you what's the limitation of that. Uterine natural killer cells are cytokine producers. They present early in pregnancy in the decidua in response to the trophoblastic antigens. So these are the dominant lymphocyte in the uterus. If you want to think about natural killer cell, think about what is the lymphocyte of the uterus. Lymphocyte of the uterus is the natural killer cells. It's roughly 70% of all the present lymphocytes in the uterus. However, practical assessment of the NK cells in patients is difficult. So there was a review that noted that NK cell evaluation in endometrial tissue is prone to errors, and the peripheral blood evaluation is much more objective, much more practical, and it's, as stated above, the peripheral levels are not indicative of the uterine cells. So the only drawback that the peripheral does not mirror image the uterine. So we take it, the peripheral assessment of the natural killer cells just as a clue to whatever happening, especially in the unexplained cases. These are the names of the specific tests and the ratios if you're interested. So I would say that whenever you have a problem with unexplained recurrent pregnancy loss, you need to refer this woman to the specialized center if you have one. If you don't have one, send her to the best person who has a great expertise in the field. So don't treat if you are like junior or if you don't have the capacity to follow up the patient, because this is very complicated and they need a lot of care. So the polymorph nuclear leukocytes and its role in the recurrent pregnancy loss. These are active during tissue remodeling. They promote angiogenesis, especially in the set of infection. They produce defensins, which promote endometritis, which is a current known cause of RPL. As I mentioned to you, endometritis and infections inflammations play a role in RPL. The T cells, our immune system is very, very important. And I'm telling you, all over the years, even when we were in medical school, they didn't put so much emphasis on teaching us immunology. And I believe that this should change, because the new medicine right now depends on the understanding of the immunology. All the diseases you are dealing with, there is underlying some sort of immunological factor or background or pathogenesis happening. So this is important for the stakeholders to look into that. So T cells, the T cell expression and regulation is an important process in the establishment and maintenance of early pregnancy. There are still many unknown regarding the mechanism of action, but estrogen, beta HCG, and the GCSF are all well known to induce expression of the Treg cells. I put this here. I know this is very sophisticated, but I want you to be familiar of the terminology like the Treg cells. Okay, and they express interleukin 10, TGF-beta, and TNF-alpha. TNF-alpha is produced also by all CD4 cells. These are the T cells. Interleukin 10 inhibits macrophages and Th1 cell proliferation. Th1 cells, they both produced and promoted by the interferon gamma. They secrete interleukin 12 as well. They can induce Th17 and NK cells. Th2 cells produce interleukin 4, 5, and 13, and it's known to inhibit Th1. So the idea of this that there is a simple test called Th1, Th2 test. This is a blood test. You send your woman if she has a recurrent pregnancy loss, especially if it's idiopathic. You send her to the lab. You send her to a big lab. It won't be the small labs. And you ask for Th1, Th2. And if the result comes back as a disbalance between Th1 and Th2, you know that this woman might benefit from a very important medication I'm going to talk about very shortly. So that's the idea why I included all these sophisticated slides. You don't want to retain it in your brain. You just have an idea because you need to request the test, the Th1, Th2, which is the balance that you want to know. This woman at balance or disbalance. So how could this affect our management? Steroid therapy has been used in the past with autoimmune diseases and recurrent pregnancy loss and may be beneficial for the unknown etiology, as it has been shown to increase the TRAG. You remember the TRAG I told you? It improves the TRAG function. But prednisolone has also been shown to reduce uterine natural killer cells levels in the patients with recurrent pregnancy loss. The protocols for those specific medications, I didn't include it in my talk because it's very, it needs another talk to talk about the protocols for each of those. For the low molecular weight heparins, for the steroid therapy and how to give steroid, how to titrate them up, and how to follow the woman on it. And I believe in the role of steroids, although the studies and the research medicine, they did not give us a conclusive evidence about this, but I know practitioners that they are following those protocols, especially when those desperate couples where the woman, she lost 3, 4 or more or whatever, and she's desperate to have a baby, steroids might help. So what about the role of progesterone? This is, again, another gray area in recurrent pregnancy loss. Progesterone could be a treatment for recurrent pregnancy loss by normalizing the expressions of genes involved in implantation. Some of those dysregulated in the patients with out-of-phase endometrium or abnormal cyclin E level, that is, it was controlled by progesterone. That's why they found those women, they have problems. So when they give them estrogen, it changed the expression patterns by the progesterone administration. So possibly it might have a role. While there are currently ongoing randomized controlled trials to evaluate the role of progesterone in recurrent pregnancy loss, current literature is conflicting and would overall not support its routine use. When we say we do not support its routine use, it doesn't mean that it's contraindicated or don't use progesterone. It depends that it says that it depends on the assessment that of your patient. It would be an individualized assessment of each patient scenario, and you would decide to combine stuff like steroids, progesterone, low molecular weight heparin, aspirin, etc. What about the paternal leukocyte immunization? Actually, it has been tried, and treatment to reduce the maternal NK cell response to fetal circulating antigens. And at the end of the day, they mentioned that there was problems with its use and the data are also conflicting. So the largest trials have shown no benefit. So nobody is using this right now. IVIG, intravenous immunoglobulin. It was in the past, it was tend to be used, but I will tell you a lot of troubles with the IVIG right now. So it has also been studied as a means of suppressing the maternal immune response. Results of multiple studies have failed to show the benefits of improving the pregnancy outcomes in patients with recurrent pregnancy loss. So the first rule in medicine that you need to give a medication that is effective. You need to give a medication that is not without side effect, because it doesn't exist yet, but with the least side effects to the woman. So they didn't find it effective, and it has a lot of problems in terms of its side effects. Intralapid therapy, I see it more effective with less side effects. So in vitro investigations have revealed the ability of the intralapids to suppress the natural killer cytotoxicity, and evidence for both animal and human studies suggests that intralapid administration intravenously may enhance implantation and the maintenance of the pregnancy. So when the patient has abnormal NK cell level or function, there is insufficient current evidence of acceptable quality to permit assumptions that intralapid therapy is an effective treatment for women undergoing repeated implantation failure. But in recurrent pregnancy loss, it has a role. And I'm telling you, I know some infertility centers, renowned centers here in Canada and around the world, they use the intralipid, and some of the patients, they would have a response. So that's why I told you, ask for the TH1, TH2 disbalance, and maybe in another talk in the future, we could speak about the protocol for the intralipid. Infections and recurrent pregnancy loss. Any severe infection that leads to bacteremia or viremia can cause sporadic miscarriage. The role of infection in recurrent miscarriage is unclear. So if an infective agent to be implicated in the etiology of repeated pregnancy loss, it needs to persist in the genital tract. So if I want to blame you as an organism that you are the reason of recurrent pregnancy loss, you need to stay in the genital tract. So most of the infections like the torch, like toxoplasmosis, like rubella, cytomegalovirus, herpes, listeria, they do not fulfill these criteria. So they do not persist. If it happens in one pregnancy, it won't remain until the second. So how are you blaming those infections for the recurrent pregnancy loss? So stop asking the woman to do a panel of those infections while it's not. If rubella, if the woman is planning to become pregnant, it's advisable that if she is rubella non-immune, that she doesn't have the IgG against rubella, that you give her the vaccine before becoming pregnant. And if you do so, say that you need to give her effective contraception for at least 1 month before becoming pregnant. So give her the vaccine if she doesn't have rubella immunity, and let her stay away from being pregnant for 1 month. It's the same recommendation for the many other vaccines, to stay at least 1 month before giving them, allowing them to become pregnant. There are pertinent and ongoing studies. There is a study called PROMISE. This is progesterone in recurrent miscarriage trial. They involved 836 women with idiopathic recurrent miscarriage, randomized to receive either 400 milligrams of vaginal micronized progesterone twice daily or placebo from the time of the positive pregnancy test to 12 weeks of pregnancy. And this is the most important period, because like, I know that in some areas of the world, I won't say where, you prescribe progesterone for everyone, for a woman and her husband and her grandpa and grandma and the kids in the family and the neighbors. I don't know why, but I'm telling you the proper time, even if in a case of recurrent pregnancy loss, you want to prevent the RPL, you give it from the time the positive pregnancy test to 12 weeks gestation. And despite this, there was no difference between those groups in the miscarriage rate and in the live birth rate, although we believe that progesterone is helpful. And this is the results of the study. I know that we need more randomized controlled trials and more evidence in order to understand better our management of the RPL patients. So in contrast, there was another randomized controlled trial that involved 700 women, also tested whether the same dose of vaginally administered natural progesterone would benefit unexplained RPL. But unlike the PROMISE trial, the trial commenced the treatment in the luteal phase immediately after documentation of ovulation, using either ultrasound or the LH kits to detect ovulation definitely, and continued until 28 weeks. So they prolonged the progesterone. And the Egyptian trial found significantly lower miscarriage rates and higher live birth rates. So this might, I would say, explain why the progesterone worked in Egypt and it wasn't the same in other areas. So this is a very complicated algorithm, but I'm gonna just explain it to you very quickly. Whenever you see a patient who is desperate with a couple coming to you with a recurrent pregnancy loss, first off, you need to be a human being before being a physician. You need to understand, to listen, and to communicate with those couples sensitively, because when you are using terms that are insensitive or hurting their feelings, you are actually not helping them. Even if you are the best doctor ever in whatever place, you are hurting them, and you cannot imagine the psychological impact of this problem on the woman and the couple, because it's something like, imagine yourself if you are going for an exam and unfortunately you fail the exam. You have a very bad feeling. Then you go again to the exam and you fail the exam one more time. And you go to the exam and you fail for the third time. You feel horrible. What about this is the ultimate goal of their relationship and the ultimate goal of their life together if they decided to have a baby. So this would be like a goal for them to have a live born. So be very sensitive. Emotional support is proven to work. It's already evidence-based that if you are a nice and kind doctor to your patients, spending time with them, you do eye-to-eye contact, you explain to them the different risk factors, you do a lot of education, and you be nice and you be respectful in terms of the resources allocation to your community and everything in your practice. If you do it in a proper way, you manage at the end, at least to let them, have hope. And don't give them false hope. If you know that there is a big problem, that it's not treated or it's very difficult, say it frankly and honestly. Don't give them false hopes, because false hopes will work even worse than just reassuring them because you want them keep coming to you to request more investigations. So by this, I would stop for my talk, but I would continue for the post-test. I hope you enjoyed my talk, and if you concentrated and you paid attention, you should be able to solve the questions one more time. First question, and this time I won't read it for you. It's here on the screen. You could read it for yourself. Next question. Third question. Fourth question. And the last question. So let's go back and I will tell you the proper answers for each of the scenarios. So for this lady, she's G3P0 plus 2. She's at 9 weeks gestation. She comes to you pregnant in the emerge. She has vag bleeding for 24 hours. She had a positive pregnancy test 4 weeks ago. Episode stopped by the time she arrived at the hospital. Serum beta HCG is negative. Ultrasound reveals empty gestational sac. So while the provider sensitively counsels her and everything, and she blames herself, and this is a normal scenario when women, they come to you and they are upset. They are upset and they don't know, they are desperate why she loses the baby, and she starts questioning her body and questioning her ability. So the most common cause in this scenario is the aneuploidy. So aneuploidy, which is if the chromosomal makeup of the baby, because why I chose this aneuploidy in this case? She's only 25-year-old, okay? And she's para0 plus 2, this is her time. This time she's 9 weeks pregnant, and she tends to lose those babies biochemically. So I wouldn't say it's a recurrent pregnancy loss in this scenario. It's an early spontaneous miscarriage. So aneuploidy is the reason. The genetic makeup of the baby, the seed is not good. And this is quite common. You need just to counsel them and you tell them that keep trying, will have a baby, they're gonna do it at some point because there is no problem related to the mother herself. It's related to the genetic makeup of the baby. This was the first scenario. The second scenario, it was about a 28-year-old. She came for evaluation of RPL. She had 2 miscarriages, had been trying to have a baby 2 years ago, has no known medical problems, so she's medically fit. She did have a blood clot in her leg while taking OCP 5 years ago. This is a quite common scenario too. Young lady, only 28-year-old. She took the pill. She got a DVT. She got a blood clot in her leg. Physical exam shows a mottled reticular vascular pattern on the legs bilaterally. So this is the description of what? You tell me, antiphospholipid antibodies. That's why I told you in this scenario, she is young, she took the pill, she got a DVT. That's not normal for a normal person. This girl, she had an underlying problem with the antiphospholipid antibodies. 32-year-old G5P0, even worse, at 10 weeks, came for you to assess her. She wants to have a baby, and she reports having a history of previous 4 recurrent miscarriages at 8, 10, 12, and 14. Careful to the history. History is very, very important in this case. It does not reveal a single abnormality, which is frustrating. Provider request pelvic ultrasound, unremarkable. In this case, that's the importance of testing for TH1, TH2 disbalance. So please, this is an important test. You know, you need to go to ask you the labs around you in your areas, whatever area that you are residing, ask them about the availability of TH1, TH2, because it's important in those cases when they come with this history like. I just put the scenarios because I believe that it's gonna remind you with what you will do in real life. So this scenario, she's 19 weeks, severe pelvic pain, vag bleeding for the last 2 hours. Her history is significant for 2 previous miscarriages, ultrasound, gestational sac, 28 millimeter in diameter, with no obvious yolk sac and no signs of fetal cardiac activity. Uterine anomaly is also present. So he's asking about what's the most common uterine anomaly causing recurrent pregnancy loss in this patient. And remember, I told you, it's the septate uterus. It's the most common that causes in the second trimester. She's 19 weeks, although it would never be the reason for the previous scenario like this, where she tends to lose babies at this. I wouldn't say this is go for hysteroscopy because this might be a septum. No, it's not in this scenario, but in this scenario, yes. So a 36-year-old female presents with a recent history of spontaneous miscarriage. She has a history of 3 recurrent spontaneous miscarriages in the past 3 years. So she's been desperate trying, and she has a history of blood clot in the left leg, was on the oral contraceptive pills 5 years ago as well. And she reports positive family history and DVT in her mother. She states she's a smoker, another risk factor, and she smokes 1 to 2 cigarettes per day. You need to counsel her to stop smoking. So the underlying etiology in this case is very obvious. It's the thrombophilia. It's not the OCP. It's not the smoking. It's not the septum. It's the thrombophilia. So go and screen her for hereditary thrombophilias. Thank you so much. I really enjoyed the talk with you today. Our webinar was hopefully successful, and I'd like to see you in the near future. Special sincere thanks to our sponsor, SonoScape, and all the wonderful team there. I thank you so much. And special thanks to the great foundation, Egyptian Fetal Medicine Foundation, and Pure Spot, who did a lot of work behind the scenes. I thank you all very, very much. Thank you.
welcome back again. Really, I do appreciate Dr. Heba for your nice and very organized presentation for this complicated topic, I see. But you and take some time for a question for you.
Sure.
It looks like the first is the role of hyperthyroidism for RBL.
Yeah, so the evidence usually they talk about the hypothyroidism more than the hyperthyroidism. Hypothyroidism, especially with the presence of thyroid antibodies. But still, I wouldn't say that I would exclude any medical condition that it needs optimization. So if it's not a known cause that hyperthyroidism causes RPL specifically, but if the woman has a hyperthyroidism, Graves' disease, it needs to be optimized before thinking to get another baby, not to blame the condition. So any condition, when it's uncontrolled, it might have other even implications on the pregnancy itself, even when the woman is pregnant. We know this. Thyroid hormones are crucial and very important for the pregnancy and the well-being of the baby. Thank you.
Okay, thank you. If the father has uncontrolled the diabetes, does it affect the baby outcome as the maternal factor as well or not?
Yeah, so maternal diabetes is very important. And as I mentioned, if the woman has a diabetes and it's controlled, she is like any other woman without the diabetes. If the woman is uncontrolled, that's a problem. Let's come to the men. Men, when they have diabetes, it affects them differently than women. So we know that the diabetes would affect the semen quality, that it might make the problems with the infertility from the beginning, not only the recurrent pregnancy loss. So again, optimization of both the couples, they would be seen in an endocrinology clinic. They should be multidisciplinary team looking after them. So I would definitely, if the father is diabetic and they have a problem like the recurrent pregnancy loss, there are some tests like DNA fragmentation. I didn't go into this because it's more on the recurrent implantation failures and stuff like that. But I would believe that optimization of both partners' condition is very crucial.
Okay, another question. It's really a practical one. If the provider decided to start with the mother to start with heparin and aspirin, at which gestational age she has to stop before delivery? Right. Is that a gestational age available to start with or to terminate the therapy?
Yeah, this is also important. So we used to give the aspirin until 35, 36 weeks and we stop it. And we believe now that even if a woman comes and continues on the aspirin until before the delivery, there is no big harm. It's short-lived and it doesn't affect the coagulation system that you think. And the heparin, the low molecular weight heparin, it has a protocol. If you are giving a woman a prophylactic heparin in pregnancy, you need to stop it 12 hours before she is going into labor. And if you're giving her a therapeutic dose, you need to stop it 24 hours before. So if she's taking the low molecular weight heparin.
The question before the last, in our region, the consanguineous marriage are very common. So do you think there is increased risk of recurrent pregnancy loss in these families?
Yeah, and I believe so.
Okay, and what premarital test can be done?
The premarital test. Yeah, that's a very important question. So unfortunately, we don't have a structured premarital, in most of the countries, but I would advise that we do have premarital clinics. This is really important for the optimization of health conditions before getting pregnant. And even for normal couples, they want to screen themselves for diseases. But the problem with the recurrent pregnancy loss, as I mentioned, as per the definition, we wouldn't know that these couples, as consanguineous couples, would suffer from this problem until they are married and they start trying. But there are no certain conditions, like as I mentioned, if the man is diabetic, or if the woman is having like thyroid problem, or if there is something that is known, it's very important to be optimized before conceiving, taking all the vaccinations before conception, taking folic acid for the woman plays a very important role. If the man is taking any medications, it needs to optimize. So these are the things in my mind right now regarding consanguinity and the thinking about the problem. So if we do have a specialized premarital clinic, it would definitely be helpful. And we could, you know, I would personally, if I have a couple like this, I would spend more time with them counseling about their individual risk.
Okay, the last one, I think it is a technical question rather than as a clinical one. The normal value for TH1 to TH2 ratio, there is average range?
Yeah, so you need to check with the laboratory reference for each lab, but the idea is at this balance. So it's a disbalance between the TH1 and TH2. It's not a certain value we are looking for. So it's a ratio between the two, and we want to check the reference labs for this.
Thanks, Dr. Heba. There is a lot more to talk about this topic, actually. And again, we are pushed for time. So I do apologize for those candidates, and we promise to forward all their questions, and the company, SonoScape and PearlSpot, will forward them to the speakers and get back to them. And finally, I have to thank everybody. We appreciate you are being with us today, and thanks again for joining us, and we'll see you next time, hopefully. I leave the stage for Professor Mohamed Kamal to end the webinar.
Okay, at the end, I'd like to thank you all my colleagues for this great webinar, especially Dr. Heba Mahdy.
Thank you so much.
To thank you for your time, and I appreciate your presence between us, and I hope to continue in collaboration between you and the Egyptian Fetal Medicine Foundation.
Sure.
I'd like to thank Dr. Ahmad Khatib for this great live demo. Thank you, Dr. Ahmad, and thank you, Dr. Saad, for your effort in creating this event. Thank you, Dr. Irini, Director of Egyptian Fetal Medicine Foundation, for her effort, and SonoScape with ESMAR for their sponsorship. And at the end, I'd like to thank PearlSpot for their great effort. Thank you all, and good luck.
Thank you.
Thank you. Bye-bye.